These generates an ultrasound waves which are transmitted through the body of the transducer, which houses several such crystals. Most of these ultrasound waves are scattered or absorbed by the tissue without any obvious effect. Only a few waves are reflected back to the transducer and echoed. So the reflected ultrasound waves again distort the piezoelectric crystals and produce an electrical current that is on the right side of the image. These reflected echoes are processed by filtration and amplification to get an eventually display on the cathode X-ray tube. So reflected signal gives information about the depth and the nature of the tissue studied. So most of this reflection occurs at the interface between the tissue of different density and has a different eco-reflectivity. This is the image showing how the rays pass through. Deeper structures are shown on the lower portion of the display screen, while the superficial structures are shown on the upper portion. This is because the transducer is at the apex of the triangular image on the screen. Since the wavelength and the frequency are inversely related, higher the frequency of the ultrasound, shorter is the wavelength. So the shorter wavelength, higher is the image resolution and lesser is the penetration. Therefore, the high frequency probe, that is 5 to 7.5 megahertz, provides a better resolution when applied for the superficial structures and therefore used in the children's. Conversely, the lower frequency of the ultrasound, longer is the wavelength. So the longer wavelength, lower is the image resolution and greater is the tissue penetration. Therefore, low frequency probes, that is 2.5 to 3.5 megahertz, provide a better penetration when applied for a deeper structure and therefore used in the adults. This is the Doppler equation, which we will go through it later in detail. So this is the principle. If the flow is directed towards the probe, we get a positive deflection as shown in the A image. If the deflection is away from the probe, we get a negative deflection as shown in the figure B. So by convention, velocity towards the transducers are displayed above the baseline, that is positive deflection, and velocities away from the transducer are displayed below the baseline, that is negative deflection. So we have two modes of echocardiography, that is continuous wave Doppler and one more is pulse wave Doppler. In continuous wave Doppler, two piezoelectric crystals are used, one to transmit continuously and the other to receive continuously without any time gap. It can measure high velocities but does not discriminate between several adjacent velocity components. Therefore, continuous wave Doppler cannot precisely locate the signal which may originate from anywhere along the length or breadth of the ultrasound beam. While pulse wave Doppler, in which a single piezoelectric crystal which will emit a burst of ultrasound and then receive it after a preset time gap. This time is required in order to switch over into the receiver mode. To locate the velocity, a sample volume indicated by a small box or a circle is placed over the 2D image at the region of interest. The sample volume can be moved in depth along the path of pulse wave beam indicated as a broken line until a maximum velocity signal is obtained. Pulse wave Doppler can precisely localize the site of origin of the velocity signals, unlike continuous wave Doppler. Because of the time delay in receiving the reflected ultrasound signals, pulse wave Doppler cannot accurately detect high velocity, which is exceeding 2 meters per second.
Lost you.
Sir, can you see my slides, sir?
Yeah, now we are in the same 2 meters per second slide.
I think it's
Not moving.
not moving, sir. Now is okay, sir?
I can see the slide.
Yes, sir.
The next slide. Yeah, okay. Fine.
So while comparing the continuous wave and pulse wave Doppler, in this we get a better resolution in pulse wave, while we get a aliasing, which is very more common in pulse wave, which is used in future to assess the uh, regurgitation quantities by creating aliasing through pulse wave Doppler. We will further understand these three concepts sequentially. First, pulse repetition frequency, then Nyquist limit, and then the aliasing. So the rate at which the pulses are emitted is known as the pulse repetition frequency. Obviously, greater the depth of the interrogation, more is the time interval between the pulse repetition, and lower is the pulse repetition frequency. Pulse repetition frequency should be greater than the twice the velocity being measured. So the pulse repetition frequency decreases as the depth of interrogation increases. So the Nyquist limit, the maximum value of Doppler frequency shift that can be accurately measured with a given pulse repetition frequency is called as the Nyquist limit. Coming to the aliasing, the inability of the pulse wave Doppler to detect the higher frequency Doppler shifts is known as the aliasing. Aliasing occurs when the Nyquist limit is exceeded. Aliasing is the artificial reversal of velocity and distortion of the reflected signal. The phenomena of aliasing is called as the wraparound. Aliasing can be tackled by one of these modifications: high pulse repetition frequency, multi-gate acquisition technique, reduced depth of the interrogation, or shifting of the display baseline. So aliasing occurs if the velocity of the blood flow exceeds the Nyquist limit. This implies that the ultrasound machine cannot determine the velocity and direction of the flow. On the ultrasound image, the velocity exceeding the Nyquist limit will be presented on the opposite side of the baseline. Positive velocity normally shows above the baseline, exceeding the Nyquist limit. That will be shown as a negative. As shown in the image, the upper part of the waveform will be showed in the below graph. So by shifting the baseline, we can get up the whole waveform. Coming to the different forms of echo windows, for transthoracic echo, the subject is asked to lie in the semi-recumbent position on his or her left side with the head slightly elevated. The left arm is tucked under the head and the right arm lies along the right side of the body. This position opens the intercostal space through which the echocardiography can be performed, while most of the heart is masked from the ultrasound beam by the ribs. Better images are obtained during the expiration when there is a least air tissue interface. So ultrasound jelly is applied on the transducer and it is placed on the chest at the site of the echo window. Most of the time, the left parasternal and apical windows are routinely used. The transducer has a reference line or a dot on one side in order to orient it in the correct direction for obtaining a various echo views. So the transducer is variably positioned in terms of location and direction for different echo images. It can be tilted to bring into the focus the structure of interest and rotated clockwise or anti-clockwise to fine-tune the image. So standard location on the anterior chest walls are used to place the transducer, which are called echo windows, that is left parasternal, apical, subcostal, right parasternal, and suprasternal views. Parasternal long axis view, in which a transducer is kept with its marking directed towards the right shoulder, mainly in the second to fourth rib spaces on the left side of the sternum. The structure which are seen here are proximal aorta, aortic valve, left atrium, mitral valve, left ventricle, interventricular system, septum, posterior wall, right ventricle, and pericardium. So this is the parasternal long axis view. Comparing right image shows the RV from above downwards, RV, LV, and towards the right of the image, we can see the aortic valve, aorta, mitral valve, and left atrium. On the left side of the image is the echo diagram, echo image depicting the same. The first comes the RV, then the interventricular septum, then is the LV cavity, and the we can see anterior mitral leaflet anteriorly and the posterior mitral leaflet attached to the posterior wall, left LV wall. This is the GIF image. Sir, can you see this image, sir?
Yeah.
Yeah. In this image, we can see behind the posterior wall of the left ventricle, we can see that arrow marking towards the pericardial effusion. So any hypoechoic lesion anterior to the descending aorta is most of the time considered as pericardial effusion. Any hypoechoic lesion beyond this descending thoracic aorta is considered as left pleural effusion. This is the landmark. So in parasternal short axis view, transducer is positioned in the left sternal edge in second to fourth space. The dot or the marker is pointed towards the left shoulder, that is 90 degrees to the previous view. By tilting the transducer on an axis between the left hip and the right shoulder, short axis cuts are obtained at a different levels, from the aorta to the left ventricular apex. This angulation of the transducer from the base to the apex of the heart from the short axis view is known as a bread loafing. So these are the short axis views. The first one is at the aortic level, showing the pulmonary outflow tract, RVOT tract with bifurcation. The second image at the aortic level with interatrial septum more prominent. The third is at the mitral leaflet level. Fourth is at the papillary muscle, and fifth is at the apex. So parasternal short axis view, that is pulmonary artery level. In this view, we can see pulmonary artery, valve, and right ventricular outflow tract. So this is the short axis view at the aortic valve level, that is showing the Mercedes-Benz sign of the aortic trileaflet, in which we can see a aortic valve at the center, left atrium just below it, interatrial septum next to the left atrium to the left of it, tricuspid valve, and the right ventricular outflow tract. Parasternal short axis view at a mitral valve level. In this, we can see a mitral valve orifice, mitral valve leaflets, and ventricular septum. In this, in future, we can assess the mitral valve orifice area by using a planimetry. We can assess the opening area of the mitral valve. By that, we can grade the severity of mitral stenosis. So this is the GIF image showing the anterior one is the anterior mitral leaflet, posterior leaflet is the posterior mitral leaflet, and the circular one is the left ventricular cavity. While the left side of this circular, that is LV cavity, is the right ventricle, which is a crescentic shaped, while the LV cavity will be the circular in shape. This is the short axis at the papillary muscle level, in which we can see the anterolateral papillary muscle at 3 o'clock, posteromedial papillary muscle at the 7 o'clock, anterior wall from 12 to 3 o'clock, lateral wall from 3 to 6 o'clock, inferior wall that is from 6 to 9, and interventricular septum from 9 to 12. So this is the GIF image showing the papillary muscle, that is posteromedial and the anteromedial. And we can see the very well circular contraction of the left ventricle shows good contractility. These function we use in the systolic assessment of the left ventricle. So apical four-chamber view, that is transducer position at the apex of the heart. The marker is directed towards the left of the shoulder. The structures seen in this are, in the image we can see, that is from the top on the right hand side left ventricle, then the mitral valve and the left atrium. On the left hand side is the right atrium, tricuspid valve and the right ventricle. Further going into detail of four-chamber views, this is on the right top hand side of the left atrium. That is, we can see a descending thoracic aorta. This is on the right side, we can see the descending thoracic aorta. Further going into the detail of the left atrium, we can see a right superior pulmonary vein, left superior pulmonary vein, and inferior pulmonary vein. This helps in determining that left atrium is morphologically a left atrium because it is receiving a pulmonary vein. And this is the image showing the four-chamber view. This is the image where on the posterior tilting the probe posteriorly, we can get a coronary sinus transversely through the we can see it is draining into right atrium. So apical five-chamber, in which tilting a probe downwards and directing upwards, we can see opening of an aorta. View is obtained after a four-chamber view by slight downward tilting of the transducer in a fifth chamber. That is called a fifth chamber. The transducer is positioned as a apical four-chamber view. Marker is directed as in fourth chamber view, and structure we can see is LV, outflow tract, aortic valve, and proximal aorta. So this is the apical five-chamber view. We can get a aortic valve, LVOT, and the part of ascending aorta. In subcostal view, the position of the subject is different from the used to obtain a parasternal and apical views. The subject lies supine with the head held slightly low, feet planted on the cough, and the knees slightly flexed. Better images are obtained with the abdomen relaxed and during the phase of inspiration. Transducer is positioned at the CP sternum with a marker directed to the left shoulder. The structure which we can see here is inferior vena cava, descending aorta, interatrial septum, and pericardial effusion. This is one image in which we can beautifully see the interatrial septum, and we have to comment atrial septal defect through this view, because in four-chamber view, if we are assessing the interatrial septum, most of the time it is wrongly detected or there are dropouts which are diagnosed as an atrial septal defect. So this is the view in which we can see the upper part is the liver. First comes the liver, then is the RA, RV, and the tricuspid valve, and the interatrial septum, left atrium, and left ventricle with the mitral valve. So pericardial effusion, interatrial septum, and the inlet ventricular septal defects are beautifully assessed through this subcostal view. Suprasternal view, the subject lies supine with the neck hyperextended by placing a pillow under the shoulders. The head is rotated slightly towards the left. The position of the arm or the leg and the phase of respiration have no bearing on this echo window. So the transducer position in the suprasternal notch with a marker directed towards the left jaw. Structures which we can see the total arch and its main branches, that is right common carotid, right brachiocephalic, common carotid, left common carotid, and subclavian arteries. So this is the suprasternal view, which we can through which we can see the ascending aorta, arch, and descending aorta with its branches, innominate, left common carotid, and left subclavian. In the center of the arch, that is a pulmonary artery, which we can see. This is the view which is helpful in diagnosing the aortic dissection flap to assess its extent, whether it is a type A or type B aortic dissection. And this is also the view through which we can assess the patent ductus arteriosus. Coming to the next mode of the echocardiography, that is M mode, the transducer emits an ultrasound beam which reflects at each anatomical interface. If the B mode scan is swept from left to right with time, an M mode image is produced. The reflected waveforms can be represented as the dots, that is B mode, and as a spikes as a mode. So brightness of the dot or the magnitude of the spikes vary with the amplitude of the reflected waves. So this is the image, simplifying the same. So B is the dot format, A is a spike form, and M mode with the time we can see the whole structure with the reference to time. So M mode has got a better temporal resolution and thus subtle abnormalities in the motion and timing is better appreciated. For example, systolic anterior motion of mitral valve in hypertrophic cardiomyopathy and RV diastolic collapse and tamponade can be better appreciated. Because of its high sampling frequency, M mode has an excellent axial resolution and is useful in identifying the relative location of the structures and measuring range of the motion. So with the M mode, we can appreciate the morphology, time interval, and velocity and amplitude. So first we will understand the level of M mode cuts from 1, 2, and 3. 1 is at the LV cavity, second is at the mitral leaflet, and third is at the aortic valve and the left atrial level. So this is at the left ventricular cavity level, wherein this is the dimensions which we will understand further. This is left ventricular M mode ultrasound, in which we have took the short axis view at the papillary muscle and then assess the measurements of the left ventricle. On the right hand side top, it is the mitral leaflet level M mode, and the downward the below image is at the aortic leaflet and left atrial level. So understanding the measurement of the left atrium, interventricular septum, LV cavity and posterior wall, left atrial measurement is 4 centimeter, while interventricular septum taken as 1 centimeter and 5 for the LV internal diameter. This is the rough dimension which we have to keep in mind: 4, 1, and 5. 4 for LA, 1 for interventricular septum, and the LV is 5. That is the rough dimension irrespective of gender, mainly for adults. So this is the anterior most part is the right ventricular wall. Right ventricular wall, mainly used to compare the thickness of the right ventricle and left ventricle. This is the right ventricular internal diameter. This is interventricular septal diameter. Left ventricular internal diameter in diastole. The small d is a diastole. And the posterior wall diameter mainly in the diastole. Coming to the M modes, mainly through these parameters of the left ventricle, we can assess the chamber enlargement, that is the left ventricular chamber, and comparing with the right ventricle, we can assess whether RV has got hypertrophy or not. With these dimensions, the echocardiography machine will give us the rough idea of ejection fraction, how much that shows the systolic function of the left ventricle. This is the M mode at the mitral leaflet level, in which this is the normal view, in which we can see the markings of seen on the anterior mitral leaflet, and the posterior part, that is below the F part, we can see the posterior mitral leaflet movement. So the marking of D, E, F, A, and C are on the anterior mitral leaflet. So this is the M mode in which we can see the B marking. If it is present, we can say that there is a increase in the left ventricular end diastolic pressure, elevated LVEDP. So this is the classical. On the left side, we can see the normal mitral leaflet inflow, mitral leaflet M mode. On the right side, we can see the classical mitral stenosis M mode. On comparing, we can see that there is a anterior mitral leaflet thickening that is more denser than the normal. We can see the anterior diastolic movement of the posterior mitral leaflet, and the slope that is E and D, that is marked with yellow, has reduced, and the green arrow pointing towards the early diastolic contraction of the interventricular septum. So these are the typical mitral stenosis features in MO.
Sorry, let me interrupt you. It is
Sir?
not the E and E slope. It is EF slope that is more important. The
Yes, sir.
EF slope, which is much more slanting in a normal valve,
Yes,
will become flatter because of the thickening of the leaflet, and then the posterior leaflet, which usually goes away from the EF slope, starts migrating towards the EF slope. That means the both will start moving anteriorly, and that is the classical picture of mitral stenosis.
yes, sir. I have mentioned that.
Yeah. Yes, so it's not the D and E slope; it is the EF slope.
Yes, sir. Yes, sir. I have mentioned that, sir. This is the decreased EF slope, as you told, sir. And this is the paradoxical anterior diastolic motion of the posterior mitral leaflet.
Yeah, these are the two classical pictures of mitral stenosis.
Yes, sir. And this is the 2D diagram showing the anterior mitral leaflet, which is in a shape of a reverse hockey stick, and which is also called as AML domains. So, in summary, decreased EF slope, paradoxical anterior diastolic motion of PML, separate between leaflet is decreased, thickening of leaflets, and early diastolic dip of interventricular septum. This is the M mode, which is showing the arrow mark showing the systolic anterior motion of the anterior mitral leaflet during the systole. That is pathognomic of the hypertrophic obstructive cardiomyopathy. All these were the M modes at the level of the left ventricle, assessing the left ventricular dimension, its ejection fraction, and systolic function. Other than that, it is also used in RV function. So getting a 4-chamber view of the heart, and then using a M mode passing through the lateral annulus of the tricuspid valve, which will give us the image as shown in the below, that is the lower part, which will give us the excursion as shown in the image. That is a tricuspid annular plane systolic excursion. Just for a reminding, SE17, anything more than 17 is considered as normal. Less than that, there is a reduced RV function. So typical features of cardiac tamponade M mode, mainly the specific thing, that is RV diastolic collapse and the right atrial diastolic collapse, which is more sensitive. So this is the M mode at the of cardiac tamponade. We can see the RV collapse and the disparity between the RV and LV during the systole and diastole. This is the subsymphoid view, M mode, which is used for assessing the volume responsiveness in the postoperative period. So it assesses whether the IVC is partially or partially collapsed or completely collapsing. If the IVC, the lower image, GIF image, shows the IVC which makes us sure that if it is more compressible, then it is volume responsiveness.
Huh?
When you started, we were like Titanic.
No, Titanic pose, and you have to pee in the backwater.
Sir, I'm-
You all have done it.
Mute other people.
Thank you, sir.
So
Yeah,
if the yes sir, if the collapsibility is less than 50%, then we consider that RV or LV contractility is less, then we add on a inodilators. So it is one of the deciding factor in post-operative management. Before going into the color Doppler, once we tell the color Doppler, we get this type of image in our brain.
One minute.
This is
One
the
minute. Before you
yes,
go
sir.
on to color Doppler, I'd like to say a few words about the M mode. The M
Yes,
mode
sir.
was the initial mode of echocardiographic assessment, which we started with. As you said, the transducer is placed and the ultrasound beam is sent across, and then different tissues reflect back the thing at different levels.
Yes, sir.
So the normal this thing is the interventricular septum is
Yes, sir.
considered as part of the LV.
Yes,
So
sir.
when the LV contracts, the septum moves away from the transducer.
Okay,
Okay.
sir. Yes, sir.
So and the posterior wall of the LV will come up. So that
Yes,
is
sir.
how the septum moves like that. All right.
Yes,
So
sir. Yes, sir.
when the RV gets dilated or becomes volume overloaded, like in case of ASD, then
Yes, sir.
there is paradoxical movement of the septum. The septum moves along away from the RV outer wall, and it goes towards the LV cavity.
Yes, sir.
So I mean towards this that becomes the part of the so this paradoxical movement of the IVS is considered as an RV surrogate marker for RV hypertrophy.
Okay,
All
sir.
right. So
Yes,
that
sir.
is one of the reasons. That is one of the things that you assess on the M mode.
Yes, sir.
Next is of course the cavitary size. The ESV and the EDV is much better calculated in the M mode because it is just a simple planimetry sort of thing
Yes, sir.
about downwards diameter. Similarly, the thickening of the muscles,
Yes.
the interventricular septum, the RV free wall, and the LV free wall. So these are better assessed by M mode. And then of course the EF slope and the planimetry that comes later on. But the planimetry is better seen on the 2D echo. So what you
Yes,
have
sir.
been seeing all this while was a 2D echo. So
Yes,
the
sir.
2 is that the echo transducer sort of tells you in a 2-dimension as single dimension in M mode. And then comes the Doppler. Doppler will diagnose the velocity or the flow characteristics of
Yes,
the
sir.
blood within the cavity. So that is how the echo is being done. First they do M mode, then they do the 2D, then comes the color Doppler.
Yes, sir.
Okay.
Yes, sir. This is the GIF image showing the four-chamber view. Color Doppler was put on the mitral inflow. Here, the main the blue signals which we can see at the level of the mitral leaflet is the mitral regurgitation jet. That is a central mitral regurgitation jet. Let us go further in detail. It was a Christian Doppler who was an Austrian physicist famous for this Doppler effect. He was a mathematist as well as the physics. Sorry. He published a book on a color light of the binary stars and some other stars of the heaven. Head of Institute of Experimental Physics, Vienna University. It was the Doppler effect that was proposed by Christian Doppler in 1842. change in the frequency of the wave for an observer moving relative to the source of the wave, commonly heard when a vehicle sounding a siren approaches, passes, and recedes from an observer. That is the received frequency higher during the approach, identical at the instance of passing by, lower during the recession. So main goal of the Doppler is to detect the flow in the vessels, direction of the flow, whether it is arterial or venous, which is normal, can be abnormal, and also the velocity flows. So continuity equation, which is no more used, that is continuity equation states that the amount of blood flow through one cardiac chamber is the same as the blood flow through other chamber and orifices. It is based on the principle of conservation of mass. Whatever mass flows in must flow out. So this is the velocity time integral parameter which can be calculated from the Doppler, color Doppler. Calculation of the volumetric flow is a complex as flow velocity is not constant. So blood flow is pulsatile. Hence the integral velocity over time is taken. That is VTI, which is equal to area under the curve, which is in centimeters per second, into the time, that is seconds. Measure of distance that blood moves with each heartbeat. VTI is also referred to as a stroke distance. So this is the VTI, which is obtained by tracing the leading edge of the velocity spectrum. If the waveform is full, that is full dense, it is mainly suggestive of continuous wave. If it is having a hollow, only the margin is showing a white opacity, then it is a pulse wave Doppler. One thing that can differentiate between continuous wave and pulse wave. The clinical application is, one is to calculate the valve area and regurgitant volumes and fraction. We can also estimate a regurgitant orifice area and also a intracardiac shunt ratios. So in MR, this is the criteria. So to know all this, we will know how to calculate a vena contracta, as it is a useful component of assessing the aortic regurgitation as well as a mitral regurgitation. So before that, we will assess the color flow area that is identified mainly in the central jet. So all this parameter is only possible through a central jet, not possible through the eccentric jets. If we are assessing these parameters, that is vena contracta and regurgitant fractions, it will be underestimating if we are using those parameters. So mild MR will be less than 20% of LA size, moderate is 20 to 40, and severe is more than 40% of LA size. So vena contracta is the area of jet as it leaves the regurgitant orifice. It reflects thus the regurgitant orifice area. So first we have to take a plaques, that is parasternal long axis, in a take a 4 chamber. Then we have to identify the 3 parameters, that is vena contracta, proximal convergence, and jet into LA. The smallest vena contracta, that is mean vena contracta width, can be better viewed by 4 and 2 chamber. This image showing on the right side the vena contracta, that is the least width through which the regurgitant jet exits, and this is the flow convergence at the orifice. So vena contracta, which is less than 3 mm, considered as mild, something more than 7 mm, and mainly these parameters to be used in central jet, not in eccentric jets. So this is the image showing a 4 chamber view, taking a color Doppler at the mitral valve, reducing the aliasing velocity. This will create the aliasing at the level of the mitral inflow, and we get a hemicircle showed in the orange image, orange hemicircle. These hemicircle, we measure a radius of this hemicircle, which is used as a PISA radius. So VA the velocity at which we get a aliasing, this hemicircle is called as a aliasing velocity, and R is called the PISA radius. And always this radius to be used in a central jets, not in a eccentric jets. So the parameter which here measured here is a PISA radius. On the right hand side, that is -29. It is a aliasing frequency, aliasing velocity. So we can measure a flow by using this radius and aliasing velocity, and by using this flow divided by a peak velocity, we get an effective regurgitant orifice area. Now this peak velocity is obtained by using a color Doppler in the regurgitant jet here below the image, and the regurgitant volume is derived by multiplying effective regurgitant orifice area and velocity time integral. Further assessing the volume assessment of the left mitral in the regurgitant volume, we can assess the stroke volume, mitral inflow, and stroke volume LVOT, left ventricle, by using a cross-sectional area into VTI. So this is the example through which we can estimate the regurgitant volume and the regurgitant fraction. First, we have to assess the diameter of the LVOT and mitral annulus. Then, using a pulse wave, we get the VTI. We have to use those parameters in to get a stroke volume. Then we can substitute in this formula, that is SV mitral minus SV LVOT. We get a regurgitant volume, and by dividing regurgitant volume divided by SV mitral, we get a regurgitant fraction. To assess the stenotic function, we use a planimetry at the short axis of the mitral valve to assess the valve area. We will understand the pressure half time. Gradient can be assessed by using a continuous wave Doppler at the mitral inflow level, and by tracing the peak level, we get a mean as well as a peak gradients. So the gradient which is assessed by the Doppler is always a higher than the gradient which is assessed by the cath lab. That is, always in a cath lab, we assess a peak to peak gradient, which is always lesser than a Doppler assessment. So mainly we get a maximum pressure gradient and a mean pressure gradients. So assessing a valve area is mainly by three parameters, that is planimetry, that we visualize through a 2D echocardiography short axis at mitral inflow, pressure half time, which we will understand further, PISA, which we had already seen. By reducing the aliasing velocity, we get a aliasing at the mitral inflow level. We get a hemicircle, calculating the radius and putting into the equation. So to understand pressure half time quantified using the pressure half time method is based on assumption that the rate at which the gradient drops during the diastole corresponds to the severity of the mitral stenosis. Larger the mitral valve orifice area, the quicker the left ventricle will fill and more rapidly the gradients will drop. The speed with which the gradient drops can be measured from the slope of the diastolic inflow signals, that is deceleration slope. Steeper the curve, larger is the mitral valve orifice area, and the lesser severe is the mitral stenosis. To standardize the calculation, one uses the slope between the maximum inflow velocity to the time when half of the pressure gradient has dropped. That is pressure half time. Modern echo scanner automatically derives this time point. From the practical point of view, all one needs to do is align the measurement caliper to the curve, starting from the maximum velocity at early diastolic filling. In atrial fibrillation, one should use average values of the several measurements. In addition, avoid pressure half time and measurements from the cycles with a short diastole. So mitral valve area, this is the formula frequently asked, that is 220 divided by pressure half time will give us the mitral valve area. But this pressure half time cannot be used in conditions like diastolic dysfunction, aortic regurgitation, after valvuloplasty, and heavily calcified valves. Coming to diastolic function, this is assessed by using the pulse wave Doppler mainly at the mitral inflow or the tricuspid inflow level. We usually use mitral inflow patterns. Before that, we can understand the diastole of the diastole. In a diastole, there is a rapid filling, which on pulse wave Doppler we get a E wave, and followed by a diastasis, which is followed by a atrial kick, which gives a similar A wave pattern in the pulse wave. So these two, E wave and A wave, are used in diastolic dysfunction grading. And this is the tissue Doppler imaging. First, we have to take a 4-chamber view. Then, using a TDI mode on the machine, we can use a tissue Doppler imaging. Then, putting a pulse wave, that is a sample volume, over the mitral annulus, we get a wave pattern, that is S prime, E prime, and A prime. On the right hand side image, we can see a S image, that is a systolic annular velocity, and E prime and A prime, also denoted as EA and AA, early rapid filling of annular velocity, and A prime is atrial systole annular velocity. These two parameters derived from TDI as well as the pulse wave in the inflow of the mitral inflow, we can grade the diastolic dysfunction from 1 to 3. This is the further image. The first upstroke is a S, followed by a isovolumetric relaxation time. We can also assess an isovolumetric relaxation time followed by the S wave, that is closure of the aortic valve and opening of the mitral valve. Opening of the mitral valve is denoted by the E prime followed by a A prime. So in grade 1 diastolic dysfunction, we have a E by A ratio of less than 0.8, while E by E prime is less than 8. Grade 2 shows more than 0.8 to 2, and E by E prime is between the range of 8 to 15. That is a pseudo-normal pattern. First is impaired relaxation, second is diastolic dysfunction, that is pseudo-normal pattern, and grade 3, that is a restrictive pattern, in which E by A ratio is more than or equal to 2, and E by E prime is more than 15. So all these parameters are used to assess the left elevation of the left atrial pressure because of the diastolic dysfunction. So in summary, mitral inflow pattern, we get E and A. So ratio less than 0.8 is normal, while E by A ratio more than 2 suggestive of elevated LA pressure. This is the pattern both showing both the pulse wave as well as the tissue Doppler imaging. As we see, as the diastolic dysfunction progress, the E wave goes on increasing in the pulse wave, while in the tissue Doppler, we can see that the A prime goes on increasing as the diastolic dysfunction progresses. So this is the summary of the E by E prime. And E by A having a limitation, that is during athlete heart, robust relaxation, that is a suction, is which will lead to a larger E by A ratio. In hypertrophic obstructive cardiomyopathy, E velocity correlate poorly with the filling pressures. During tachycardia, it's of there is a fusion of EA beat, so there will be inaccurate measurements. In atrial fibrillation, we have an absence of A wave, which will decrease the measurement efficacy. Mitral stenosis, velocity does not reflect the filling pressures, and in moderate MR, similar to aortic stenosis, in a significant aortic insufficiency. So E prime limitation, significant MR, mitral stenosis, annular calcification, left bundle branch block or a pacing in a constrictive pericarditis, in which we can inaccurately assess the E prime. So this was the diastolic function and the summary.
Good.
Thank you, sir.
It was quite an extensive treatise on echo, but more importantly, I want all of you to see these echoes being done on in person. Okay, especially in the ICU, how to diagnose cardiac tamponade, how to see the volume status of the patient, and what is the diastolic function and systolic function post cardiac surgery. This is done in the ICU. Everybody who's posted in the ICU, when they do an echo on the in the ICU, you must stand there and watch and see what are all the measurements, and unless you see them number of times, you will not be able to remember all these data and all these values, and also more importantly the views that are used for various things. The other thing is that you should also be able to interpret these things yourself, and that is the reason why I post you all to cardiology for a month in two sessions, I think, in 2 years, one early second year or so, and then later on in this thing. The idea is in the first posting of cardiology, you must learn all the basics of echo. You must sit in the echo room, see a number of patients, see the different varieties that you get. Just 1 week will be more than enough for you to know what is what, and then make up a mind, and then see this knowledge is basically very important for you to interpret the cardiac function in your pre-op assessment as well as post-op assessment. Unless you know how to do this, you will have to be dependent on the cardiologist, and more of the time it is only a technician who is doing this, and you cannot go by that report. So it is very important to know how to do an echo, how to interpret that echo, and what decisions, surgical decisions that you are going to take. So that is the reason why echo is very important. Similarly, ECG as well. How to detect early problems, like, once you start seeing ectopics, so you have to see the electrolyte balance, then make sure that there are no irritants in the heart, like a ICD or a pacing table or some such thing. Then if it is persistent, then they may be going into some sort of lactic acidosis, giving rise to ventricular VTACs and VFibs and all that. So the patient generally gives you time. The patient there is no such thing as called sudden death in an ICU. No such thing that is there. There are various signs and symptoms that you have to pick up, and if you take corrective measures early in the process, then you can save your patients, many of them. So this is the reason why you have to spend time in the ICU. You have to spend time in how to assess these things and then take decision. Then the other important decision is the cardiac tamponade. When will you decide to take a patient for re-exploration and when not? So the pericardial effusion, the IVC collapse, and these are the main things. And just the CVP rise is not the only thing that is taken into consideration. So these are important practical measures which is necessary for every surgeon to learn. And then as you have gone to this level, then you start looking at the transesophageal echo in the theater, as the anesthetist is doing. As soon as you open the chest and they do a TEE, then to assess the things, then you interpret the 2D echo, the transthoracic echo with the TEE, correlate the two, and then take your surgical decision. You understand? All of you should go through this. This is important. Just like you seeing an angiogram, how an angiogram is done, what are the features, what are the problems, and then how to read an angiogram, how to take decisions for surgical management. These are all important things in your assessment, pre-op assessment. That is why if you don't do this, you will get into trouble. you will choose wrong patients, and then you will end up with post-op problems, and then many a time you will even lose your patients, and that is disaster. Once you start losing your patients right and left and center, nobody will start referring cases to you. You will be dubbed as a mediocre or a bad surgeon. Then you are in trouble. Your whole career is screwed. You follow? So decision making is very important, and for that these tools are extremely important. So you whatever you said, you have to read this over and over again, and go sit in the echo lab, go sit in the go watch the echo being done in the ICU. Oh, do an echo, then that's it, and then all of you will run away, or you are not even bothered. I don't know what you all do in the ICU, because there is an intensivist sitting there. You people don't take any interest. In our days, we had to do everything ourselves, right from decision of inotropes and decision of ventilation, weaning of ventilation. Everything was done by the surgical trainees, because the surgical ICU was manned by the surgical trainees. Now people think that, because you are all doing 3 cases, 4 cases a day, it is waste of time to sit in the ICU. But that is not true. Unless you know the pathophysiology of what is happening with your patient, you cannot treat it. Follow?
Yes, sir.
Okay. Anyway, good presentation. There is one more article which is specifically meant for surgeons, surgical evaluation by echocardiography. I will give you the reference. I couldn't fish it out now. So maybe a little later on, once you have learned these things well, you can do that, and that is a ready reckoner for assessment, pre-op assessment. What are all the surgical things and what are all relevant things in the echo for a surgeon? Okay.
Okay, sir.
Is there any questions by anybody? Half of them must be sleeping. Half of them must have gone for a cup of coffee. What, Sagar? You
Yes.
put everybody to sleep, is it?
No, sir.
Okay. All right. Thanks. Thanks,
Yes.
everybody.